organization. Dr. Muhammad Abdullah is a colleague and a friend, and he is a consultant in infectious disease in Al Musa Hospital, the head of infection control department in Al Musa Hospital. So, Dr. Muhammad, the floor is yours. Thank you.
Thank you, Dr. Badr. Good afternoon, everybody. I just told you it's not good to present before the lunch, but inshallah it will be light snack before the lunch. Okay, so this is the outline of our talk today about this weird bacteria, actually. So what are the microbiologic characteristics of Vibrio cholera? How does it cause disease? What the recent update? How to diagnose? What the cornerstone of treatment? How we will prevent this? And what the global strategy of the WHO? So, simple reminder of characteristic of this bacteria. It's a curved, facultative, and aerobic gram-negative bacilli. It's comma shape, like you see in this slide. It's oxidase positive, highly motile, and this has important pathogenicity in causing diarrhea in the intestine. It's very important to know that Vibrio cholera 01 and 013 serogroup are the main cause of epidemic of cholera, and this is important to all healthcare provider, especially infection control team, when they're reporting such cases in a patient presented with travel-related history. While when we talk about non-01 or non-013 serotype usually cause simple mild gastroenteritis and not causing wide epidemics. So this is just simple timeline of the history and this cholera in the story. It started 1817 at the start spread. What discovered that they think it was started in India, then it was spread to other countries in the world, in Europe, North America. The cornerstone time was in 1854 when John Snow discovered the cholera, and he linked. He's not the one who discovered. He's the one who think that it could be related to water, and he just said the famous word, let's stop the toxin, the source of the toxin. So then it was spread through a seven pandemic, and the seven pandemic, latest one started 1961 till the present. Two biotypes of the toxigenic strain. If we subdivide the toxigenic strain itself to classical biotype responsible for the earlier pandemics that we mentioned, and the latest one, E1 T12 biotype, drive the ongoing seven pandemic in multiple countries. So simply, if you know the life cycle of cholera, it's naturally found in unclean water, brackish water, coastal areas, and especially in area with low sanitation care. And simply, human will get it from that area through swimming and also the drinking of unclean sanitation situation. Then through the stool it will go to the same area, and like this will go to another person. So the transmission mainly at fecal-oral route, but remember, in the setting of the epidemics, it could be transmitted from person to person, not directly, but through using the utensils and through sometimes sharing the foods. So it can happen, but rarely. So it's a high adaptive machine organism. It's produce toxin that I mentioned already. These toxin go in microscopic level to the intestine and stimulate the program of causing severe, sometimes fatal diarrhea if untreated. So this is the global burden. At least this figure, the scale figure in the 2023, so that the new cholera can emerge every 45 seconds in sustainable population of countries, and a total of 700,000 cases, over 4,000 fatalities were reported globally. The disease affected that time around 30 countries. So it's a high burden disease in the globe. So endemic cholera can cause so these are some definitions you need to know. When we talk about endemic cholera, it's a seasonal peak that happen after rainy season. It's high incidence mainly in children, but epidemics may still occur due to climate changes. So when we talk about epidemics per se, this widespread infection to the low population immunity or previous infection, although infection will not cause long-term immunity. Example, the epidemics that happened in Haiti 2010, and then it happened in the same area in 2022. And the reason at that time related to the bad disturbances of water and hygiene in that area, and causing significant fatality later also in other countries in 2017 and Yemen, according more than 2,000 deaths. The cholera fatality major outbreaks was reached sometimes 4%, but in general it's around 1 to 4%. But the worst epidemic was in Zimbabwe in 2008 and 2028, causing significant a significant epidemic and fatality in that area, and involved also another 16 countries. So we are in the seventh pandemic that's still running record over the last 20 years till now. The current seven pandemics, the all pandemics since 20 years, 200 years, but the seventh pandemic started in 1961 till now, and it's related mainly to the serotype 01A originating in the South Asia. It's spread in 3 waves, each gaining new genetic traits that increase virulence and unfortunately with the drug resistant and environmental stability. So these are the data in 2023 show comparing to 2022 show that this type of bacteria re-emerging in the last 3 to 5 years to some factor that we will mention. And this is the data when compared 2023 again to 2024, there were rise in the cases. Despite there is no rise in the fatality, but the number is really scary when compared to the last year or the year before that, 2023 and 2024. The main factors of re-emerging of this disease and why we present it, because it's related to a major factor over the globe: the conflicts, the wars, the mass displacements of the population, the natural disaster, especially flooding. So flooding, especially with the rise in the temperature, climate change related to the rise of the hot weather, causing more flooding. Flooding, more water, unsanitized water. This is the best environment for cholera, Vibrio cholera to survive. So this is the latest dashboard from the WHO, show that this is till the end of January. This year, it's around 34 countries, and the number is still increasing, and the countries that we will mention in the next few slides. The incubation period, it can reach between 18 hours to 5 days, and it's treated with sudden onset watery diarrhea and vomiting. So basically, the clinical feature, non-specific, but cholera known to classically in the medical school that causes rice watery diarrhea, and can be associated with fatal severe dehydration. The severe complication, apart from dehydration, severe electrolyte disbalance, acidosis, especially in extremes of age, hypoglycemia, risk of seizure in children, and it can be associated with end organ failure and many complications in pregnancy. In severe cases, cholera can lead to rapid dehydration and death if untreated within hours and rehydrated. Before the introduction of the rehydration therapy, case fatality can reach 50%. With the proper management and early rehydration, it's below 1%. So the conversion of to compare the diagnostic test, and this is very important, especially for the infection control practitioner, to differentiate between stool culture, antigen molecular test, and the direct microscopy or dark field microscope. The best and the gold standard is the stool culture. And this is the best tool to get the serotyping that we mentioned earlier. You should know that this serotyping correlates with the presentation and with the history of the patient, because we have other non-epidemic serotype. The rapid antigen test reaches 70 to 90% sensitive, but there is possibility of false negative and less specific when you compare it to the stool culture. The molecular test is available, and it makes sometimes some headache between the hospital and the regional authority of the MOH about reporting the PCR result, because some of the patients, when you do the PCR for simple diarrhea, you might have positive non-epidemic strain, and the PCR will not differentiate. So it's better to have the stool culture in your lab facility to get the serotyping and to assess this in the pre-test probability when you do PCR. So you don't think that this patient highest related to the ongoing cholera, for example, and your country or your area or recent travel to endemic area. This is why we mentioned yesterday travel history essential, travel clinic essential in any hospital. And to take all, to be updated, the physician, not only the ID, need to be updated about the epidemics and the update of some important infectious disease like cholera over the globe, especially nowadays. The case definitions of cholera, again, this is important for define the case. So the definition of acute diarrhea is acute diarrhea, non-watery, stool significantly more than 3 loss within 24 hours. The cholera will be suspected if there is a case who die from the presentation with a significant epidemiological link in the area and confirmed by the laboratory characteristic features either by culture or PCR with significant link in the history, but the stool culture still with serotyping the best diagnostic method. I will go over this. So the causes of diarrhea apart from cholera should be put in the differential diagnosis when a patient came from area who has multiple epidemics, multiple factors. So this is why to think of other differential bacterial and parasitic infection upon a presentation. Assessment of the patient in the emergency room, the healthcare provider or frontliner to assess the severity on the treatment. So in general, the main important things to assess the signs of dehydration for the patient upon a presentation, then the treatment will be based on this. So mild presentation require need oral rehydration with salt therapy, while severe dehydration require intravenous fluid. By evidence ringer lactate, consider the best type of a fluid, but just rehydrate the patient with what you have. Plus the oral rehydration therapy and the step down therapy. Zinc supplementation show some evidence in children. I will show you the study. So by evidence, administration of rehydration therapy reduce the mortality for severe cholera from 10% to 0.5%. So rehydrate your patient very well. This is the ministry of therapy, more important than the antibiotics. Oral rehydration therapy, it's not only you need to have it, you need to explain the amount, half a spoon, how to prepare it for the patient, caregiver, and to explain to them and give them a proper counseling in the area when you have epidemics or increased number of cases. The oral antibiotic in general, we have 3 classes of antibiotic that should decrease the illness and the duration of diarrhea, but it's not the mortality the same as the rehydration therapy. Unfortunately, in the last epidemic and the last 3-4 years, there are a decreased level of resistance to all of these type of antimicrobial. So tetracycline, classically doxycycline, considered the drug of choice, and it's the most drug available and associated with less resistance when compared to quinolone. But again, you need to have data to say what's the level of resistance in your country or in your region. It's not recommended in general for a pregnant or children, but again, this at the end you need to discuss the risk and benefit if you have a case with the caregiver and the patient. The macrolide is classically azithromycin as a single dose. All other drugs consider single dose therapy or 3 to 5 days to decrease the illness duration and the symptoms. So there is a randomized controlled trial was conducted in Bangladesh over around 180 children show that zinc supplementation shows shorter duration of diarrhea and decrease the stool output compared to placebo. So it's recommended by the CDC and WHO for children presented with cholera to give them zinc supplementation because associated with less harm and side effects. Discharge instruction and counseling for the patient for the next 24 hours after having the episodes resolved, and how to provide them with the oral rehydration therapy with a close follow-up if you have a clinic for follow-up in your country. The prevention simply, I think Dr. Suad already mentioned a nice presentation, and she covered everything about the healthy water, drinking, sanitation. So it's not only related to the personal level, related to the country level, the global, national level, to have a clear surveillance programs, a clear leadership program to deal with any positive one case of cholera and to have a strategic plan to reduce it in case you have epidemics in your country. And to provide the vaccine, we will talk about the preventive methods. So if we talk about cholera vaccine development, it starts by Louis Pasteur in 1880 developed the vaccine for the chicken, but it was later thought to be ineffective. Then a live vaccine was created for 30,000, I think in Italy, that study, and by General Frean. Then development of the vaccine started to increase until we get the heat-killed vaccine and introduced to the oral vaccine in 1990s. There are basically two oral cholera vaccine, one inactivated and one live attenuated for a traveler. When we talk about the inactivated, we are bivalent and B subunit conjugated inactivated cholera vaccine. So when we talk about the bivalent vaccine, it's killed vaccine. It's contained the two serotype that we mentioned. It's called the epidemic, but it has no cholera toxin B unit. The cholera killed vaccine B subunit associated with more maybe stimulation for the antibodies when we talk about adding adjuvant subunit. But again, this subunit vaccine doesn't have the cholera 0139, which is not common nowadays. So both vaccine and studies showed to be effective, and I will show you some of the evidence. Now, this is the live attenuated vaccine. It's very important to know about this vaccine because this is the vaccine that's given 10 days or at least 10 to 14 days before the travel to endemic area when it's indicated. So again, I encourage you always when you travel to area that could be endemic to cholera, just open the CDC site. There is active dashboard in the CDC for all countries. So you need to know the update situation. We have a site that mentioned in each country what is the recommendation to do when you travel to that country and what the needed vaccination. So this is the latest update from the CDC for the country, most of the country in Africa and some in Asia that needed to be taken in consideration to take the vaccine. The age between 2 to 64 years of age, and it's considered indicated if you travel to a country of more than 100 suspected cases in the last year. And CDC experts also recommend to give the vaccine if you have an area that is known nowadays, for example, an alert, emergency, or urgent reports, even if it's not still have official report, not to take the risk and to get it when you have any data from the CDC before traveling to that country. So this is some of the evidence. This meta-analysis summary showed that the overall effectiveness of both killed vaccines reached around 80% of 2 doses. Still, if some area with availability is an issue, single dose even shows some efficacy can reach up to 70%, especially when we talk about age 5 to 15 years, it's around 60%, and children more than, or adults or adolescents more than 15 years. But again, the efficacy is not that much when you talk about children less than 5 years. The vaccine has advantages like some other vaccines of herd immunity. So if you give it in the community, they show a decrease the infection by indirect way. Use of the vaccine in one study show during the ongoing outbreak, if you provide it, it can provide like in this study, it can reach to about 87% protection against cholera, even in the ongoing outbreak. And this is another study done in Mozambique, so how the vaccine during the outbreak decreased the number of cases by 78%. The live attenuated vaccine associated with the decreased diarrhea frequency for travelers and demonstrating 90% efficacy in some studies. We have a lot of barriers for global control of cholera. People mention why this is all disease, why still we have it. Because of these factors that, first of all, high infectious and environmental factors, bold infrastructure in some area and gaps of having the clean water, limited availability of the oral vaccine to our countries, barrier to care for a fragile and conflict zone, cross-border transmission risk and coordination resource constraints. How to overcome this? The Task Force of Cholera Authority globally has this recommendation to have scenario planning and forecasting, investment and advocacy on this disease, supply chain availability and resource for each country, especially the country in the endemic area or epidemic area, support the Ministry of Health of each country, strengthen the country level response, cross-border coordination. This is the Global Task Force on Cholera Control to decrease the cholera death by 90% and by 2023 to eliminate cholera from 20 countries. The take away message for today is cholera remain a global public health threat despite medical advancement. Transmission preventable through safe water, hygiene and sanitation, early diagnosis and rehydration therapy are the key saving life. Oral vaccine help to prevent outbreak and to promote herd immunity and outbreak settings. Global surveillance and infrastructure improvement crucial to elimination. Preparedness and community engagement and awareness for the community reduce the mortality and control the outbreaks. Thank you.